Adventures in Learning is, what our program is today, and some of you have been to all these this year. This is what we've done this year. Our first meeting was back in February. We had Heather Sharp, talked about her book and her experiences with almost losing her life twice. Then we had Caring Bridge, remember that? Caring Bridge was there. April 11th, we had the Raptor Center there with their birds and all that. That was fun. And Laura Coble, who's a birding expert in the area here, she was there. Then in September, we're doing this one. And then in November, we have our Veterans Theme program. So we'll be having some kind of a Veterans program on November 7th, Veterans Day. And that'll be in November. That's the 4 Adventures in Learning. We try to do 4 a year, right? Well, I think it's 4. And I'm the chairman of our education committee at Shepherd Center, just to share with you. And if you have ideas, that's why I'm mentioning this. You can always call me. But our committee, we do book buddies. That's one of our responsibilities. We run the Triad program through ours, and our Triad leaders here, Rosie, where you at? Rosie, raise your hand. If you haven't been to Triad, maybe take that in. It's always the second Wednesday at 10 o'clock. at the Shepherd Center. And Rosie does a great job with that. This year, my committee's also working now with what we call senior athletics. And we had senior softball, which really went over well this year. We had 27 people. 27. Age range of 62 to 81. And our 81-year-old, I want to tell you, is pretty physically fit. He gets around really well, really good. We coordinate day trips through my committee, and then we're just starting work on a Shepherd Center anniversary. It'll be our 20th year coming up in January. So there's going to be something special put together for that. So kind of watch for that. My committee also coordinates group travel, and this year, you heard Rod talk about, this year we're going to Washington. Next year there's scuttlebutt that we might go to Nashville. So you might want to stick that in the back of your mind if it all comes about. And then we did some computer workshops this year on smartphones and Android and iPhones. So that's what my committee does, just to share with you. And I kind of enjoy it because most of you know I'm a past educator and I like to do stuff like this, so I volunteered to do that. And as far as senior athletics, we're talking about now having a senior bowling league. So if you're all interested in bowling, why contact the Shepherd Center. It'd be once a week for about 16 weeks. So it'd give you something to do for that Tuesday. We're kind of looking at Tuesdays. So if you're interested in that, if you're an old bowler, everybody can bowl yet, so it'd be good to do something like that. So some of the things that are going on. My pleasure to introduce Bill Priest, and Glenn Christian, who are operations administrators here at the Mayo Clinic, and they're going to have a great program for us. So I'll give it to you guys.
Thank you, Ken.
Well, thanks for joining us. No jokes about a priest and a Christian up here, but feel free if you want to. I feel for you guys because you get that nice group of rehab folks and everything, then you get a couple of sluggos like Glenn and I up here. But hopefully we can keep your attention for a little while and talk through some things. We want to talk about the new medical center, talk about the facility here, and afterwards give you a little tour of things. And maybe hopefully make you aware of some things that you didn't know as we go along. So, but with that, I want to start off with maybe talking a little bit about kind of the bigger picture of things, of healthcare as a whole, and then where do we in Cannon Falls fit into that, and how do we fit into those kinds of things. So, and Glenn and I will tag team as we go through today. So, healthcare is changing a lot right now, almost what you call kind of a perfect storm for disruption going on there. You know, as a nation, we're all getting a little bit older, and the baby boomers are kind of coming into that age where they need more health care, and more health care needs are going on. So you've got the demographics piece going on with it. You've also got a lot going on with health care market forces and competition. 10 years ago, if you would have told me that part of the competition in healthcare would be Walgreens and CVS and things like that, I'd have said, no, no way. But that really is where a lot of the competition, if you will, is within healthcare. And it's not just the traditional type of healthcare that we used to think of where it's a hospital or a clinic. There's an awful lot of other niches out there right now. And all that is kind of coming to bear these days. And I think we're going to see more and more of that in the future. So you've got the demographics going on. You've got different competition going on. And also you've got some government and payer initiatives. Obamacare is a perfect example of that. That was a big disruption, if you will, to healthcare. I think we can say, hey, healthcare is too expensive and we need to do something about that. Part of what Obamacare is designed to do is to help with that. But it is creating a change in the markets, in the whole way healthcare functions and things. You also have a rapid change in technology. And healthcare always has had some of that, but it just seems to accelerate more and more. Actually, we're going to show you a few of the ways that we're using technology here in the new medical center and how we try to incorporate it into the medical center. But it's an area where it's awful tough to kind of keep up with and keep current with, and it's an expensive area to keep up with and keep current with, but it also helps to create better care, and so there's some goods and bads to all of that. But it is part of a disruption or a change that's going on within healthcare and things that we need to work with and deal with. And you also have consumer factors. Real interesting how different age groups think of healthcare. We saw some data not too long ago that said, what's the number one factor for you in terms of how you choose a clinic? And if you're 20 years old, that's a very different mindset than if you're 60, 70, or 80 years old. A 20-year-old doesn't care whether it's Mayo or anybody else. The brand names don't resonate with them at all. Someone a little bit older, the brand names do resonate more. For a 20-year-old, it's all about easy access. I want to get in there anytime, and I want to do it now. I don't want to wait 5-10 minutes, kind of thing. Someone a little bit older might say, well, I want to see my doctor, and I'm okay with if it takes a day to get an appointment kind of thing. But you've got different mindsets and consumer factors coming into all of that. So a lot of this is changing right now, and this is kind of a whole big ball of healthcare that's happening at this point in time. And so I won't lie to you and say that we've got it all figured out, but I just want to give you the big picture of some things as we go forward, and then how do we fit into that here in Cannon Falls, and how do we see where some of these things might be going in the future. So you take all of that, and we can also say that healthcare costs, I don't think it surprises any of us, are going up. But in reality, also what the compensation or what we're going to get paid for is going to go down, and has gone down. And that's a reality for us in healthcare that we need to work with and grapple with. The cost escalation is not something that's sustainable. And people are saying, consumers are saying, and companies are saying, I can't pay for all this anymore, it's too expensive. So we're going to get paid less and less for what we do. How do we grapple with all of that? There's some doom and gloomers out there, and the statistic that Glenn and I see, if you think of the American Hospital Association has said they believe that 10% of the hospitals in the United States will close in the next 5 years. That's 10% of the hospitals. That's a lot. Now, I will also admit the different trade journals and whatnot that I read, I can't remember, going back a few years ever seeing, a hospital closed kind of thing. I think just about every time I open up one of those journals now, you hear about some hospital closing at some part of the country. Fortunately, I think in Minnesota and a lot in the upper Midwest, we're pretty stable with a lot of that. We've got some very well-run organizations, not just Mayo, but a lot of other organizations in the Midwest here. But other parts of the country might not have some of that, and they are more susceptible to a lot of these changes. And I think we are going to see a lot of different hospitals closing because of that. Not quite sure I believe the 10% of all hospitals, but I think that we'll see more and more of that. So you've got that going on at the same time. We've also got a little bit of the look in the mirror that we all need to do, because what's driving a lot of healthcare costs on a macro scale and even on an individual scale. This graph is a little confusing, but on the left-hand side is a triangle. So if we look at the cost aspect of it, and then we kind of compare that to the population, we can say that 5% of the population drives 50% of the costs of healthcare. Then on the base of the pyramid, about 50% of the population is only driving about 5%. So this is a healthy, fairly healthy, well population, if you will, in the middle here, not driving much of the cost. Here we've got folks with a lot of disease states driving most of the cost. So we've got kind of a small group, if you will, taking an awful lot of the chunk of the expenses of things. And on the far right, we can kind of look at the chronic disease states. Think about the chronic conditions of heart disease, of diabetes, of obesity, of elevated cholesterol, elevated blood pressure, those types of things. And the more chronic conditions that we have, the more likely that we are to kind of fall into that upper triangle of that 5% that leads to the higher costs. So we're grappling with this as a nation, as a country, and how do we kind of bring all that together where really our individual choices and a lot of what you heard earlier, do we exercise, do we take care of our health, do we have proper nutrition types of things, all those roll into chronic conditions, and are we managing those individually, and then roll that up as a broader group, how are we doing with that as a country? And that's what we're really struggling with right now. Those things aren't easy. Those things aren't easy to work with, and it's not, the issues that we deal with today in healthcare largely are chronic disease related. We still deal with some of the more acute things. You know, someone still goes and cuts their arm or whatever and needs to have kind of go in for the day and get that taken care of. But if you go upstairs into our primary care clinic right now, most of what they'll be working with day in and day out will be chronic disease states. Things like elevated blood pressure, elevated cholesterol, diabetes, heart disease, those kinds of things. Again, that's not all of it, but it's become a much larger proportion of it. So all that is kind of just to set the stage a little bit, along with, I guess, one more thing on here. It leads to a little bit of what I'll call alphabet soup of terms and words that maybe we didn't talk about 10 years ago or even 5 years ago, but now are just part of our daily lexicon with things. Things like, how do we manage disease? You know, in healthcare, we're going to get paid for the quality. It's not just the number of CT scans that you do. It's more of, are you preventing folks from hospital admissions, and how are you doing that? So it's managing the disease state much more. It's panel management. How do we, it's not just you and your doctor anymore, it's that whole care team that's working with that doctor, and they might have a nurse or two, an advanced practice provider, and they're managing a panel of patients. And how do we manage that panel of patients and help manage their disease states, and pre-visit planning, and all these is kind of a little bit of alphabet soup that I just throw up here for you to say, again, all part of that change, if you will, that we're all seeing right now in healthcare. So on a national level, that's kind of the big picture, broad picture in a condensed version. And then how do we work through some of that and work with some of that here in the new medical center, and what did we do in the design of this building to help us manage some of that and work with some of those kinds of things. So that's what Glenn and I wanted to talk with you a little bit about today, and I just wanted to tee it up at a high level, and I'll hand over to Glenn and he'll talk a little bit more, and then you get me back in a little bit too.
So change is happening, and you know that we all have to adapt to change. So we recognized that here at the medical center. We knew that we had to make changes at the medical center. I want to say that our old medical center served us very well. We should be very proud of what happened at the old medical center. There was quite a history there. Since 1957, the building was constructed. We did open in 1958, and so there was a number of years that the medical community was served well by the old facility, and so there was many persons that just did an outstanding job, and it met the needs of the community at that particular time. So, but as Bill said, healthcare is changing, and we needed to change with healthcare as it came about. And so we have designed and developed a new medical center here, and we're very proud of it. And you should be very proud of the new medical center here as well too. It's your hospital, it's your medical center. We are the people that just take care of you, but it is truly your medical center, and we appreciate everything that you've done to provide us with this brand new facility. So change needed to occur. So we moved to a new location, and you found your way out here, and hopefully you found your way out here. I know that some of you had to go maybe through the roundabouts, and that's maybe not the easiest thing to go through, but again, that's change, and we were talking to MnDOT, and we were talking to the county, and we were talking to the city about the changes that needed to take place, and roundabouts are the new way of getting here. So we had to maneuver through that. So change is happening, and we'll get used to it. We'll figure out how to get here, and obviously you all did today. So we have an address change, we have a telephone number change, and that's listed on the sheet. So by the numbers, how many beds do we have in the new medical center? We have 15, and we have all private rooms at the medical center. We listened to the community in terms of what the community wanted us to provide, and having a private room is what the community wanted, and so we designed private rooms into the facility. We had to do a better job of providing emergency room services in the medical center. If you had been to our older facility, we had 3 bays where we took care of patients, and now we have 5 bays. And we have rooms that are more designed towards examination, and then more rooms that are designed towards taking care of the critical needs of patients. And when you have the chance to tour through that, you'll be quite impressed by that. We have 24 exam rooms where you go up to our clinical space, and we have neighborhoods in those spaces, the blue neighborhood and the green neighborhood. And some of you probably have experienced that already to see what that's like. But we have more exam room space that's provided. We got to use the toilet. And so those private rooms, we have showers, we have toilets within each one of the rooms, but just around the facility itself, we needed to provide more facilities that met that. Sinks, if you have toilets, you have sinks. And if you have toilets and sinks, you gotta have showers and tubs. And so we have showers and tub space. And then the eye wash stations are put in to take care of our staff better, and they're more appropriately located throughout the facility. So these are some of the changes that we needed to make by the numbers. We couldn't have done this, again, without our staff working with the community, but also that partnership with the Mayo Clinic and the Mayo Clinic Health System. And so we needed that partnership to do that. As we mentioned, healthcare is changing. We needed to bring in the new technology. You're all hearing we no longer use a paper record. We now use an electronic medical record. Mayo was a partner in terms of helping us to get that established in the facility. So those types of things. But just the other resources that we do get from Mayo are just tremendous. From the standpoint of specialty services or even administratively, Bill and I are constantly picking up the phone and saying, can we speak to somebody that has a legal background or human resource background or just an administrative partner that we can work with. And so that partnership with Mayo has been tremendous in terms of working with them. Just the facility overview, obviously we're bigger, and you experienced getting through the building itself. We have 92,000 square feet, where the old facility we had 35,000 square feet. So we're 3 times bigger than what we were in the past. So that was a significant change for us in regards to just physical space. Cost of the project, you look around, this is really pretty nice, isn't it? I mean, it's a beautiful facility, and everybody wants to know, what does this cost? And we had a budget of $28 million that we needed to work with, and we're very close to that budget and meeting that budget as well too. But $28 million was the cost of the project, and again, that was a partnership of working with Mayo and the community to be able to finance the building of this project. We had to bring in outside experts. We're not designers. We needed to bring in the architect and the contractor to assist us with this, and we want to recognize BWBR was the architect for the project out of St. Paul, and Bolt Construction out of Appleton, Wisconsin, and we just really think that they did a good job in terms of working with us to design what we wanted for this medical center. So it's a beautiful facility, and we're really proud of it. We do get questions about the space and the site and how much do we really have here. We obviously, if you knew some of the history, we did work with the hospital district, and Chuck Searing can attest to that. We worked with the hospital district to acquire land that was turned over to us, and there was approximately 30 plus acres that was turned over by the hospital district to us. We acquired additional land to have 51 acres of land around the medical center, and so that's our site. But we did sell back some land so that the interchange project could get built in, so we have about 46 acres to work with. So as healthcare continues to change, and we need to advance with those changes, we now have the space to be able to work with that. And so this gives us an idea of our site and the facility. So I'm going to turn it over to Bill. How did we work to?
So Glenn and I spent a lot of some in 2010, a lot of 2011, writing the business plan and what's called a financial effects analysis. And there were 18 different revisions to that financial effects analysis, and I remember. And the business plan is about that thick. And that was a lot of our pre-work, if you will, that had to be done to kind of put together. And I say Glenn and I, but it was really a lot of other people. But we had to put that together in order for the business case to be made for what we were trying to do. And we had permission to plan. And I remember the day as January 7th of 2012, where we really kind of formally kicked off our planning of the new facility by taking a group of staff. There's about, I'm going to say 35, maybe 40 of us, that we hopped on a bus and took a 2-day road trip to different sites, different critical access hospitals. And we had the architect group with us, we had the construction management company with us, but also a lot of key staff members. And went around and looked at what do we like about this hospital, what do we like about this hospital in another location, and spent 2 days doing that. It was a great learning experience for us. And we came back and then challenged ourselves and said, how do we incorporate some of that into the planning of what we want to do when we were trying to create the current facility, this building? And we came up with some key concepts or some key words there, and we saw some things that we wanted to incorporate into the exterior and some things that we wanted to incorporate into the interior of the building. And we came away with some key words and some key phrases, and then asked the architect to help design something that really met the needs or met those key words and key phrases. And throughout the project then, as different iterations came back from the architect, we would say, that doesn't have the hometown feel was one of the words that we wanted. It needed to feel like Cannon Falls. Cannon Falls is different than Rochester. There's nothing wrong with Rochester, but it's different than the Mayo Clinic in Rochester. We wanted it to feel like something that would belong in Cannon Falls, not something that might belong in Rochester, for example. So, those are the kinds of things that we challenged them to do, and I think they did a great job of that. But I give that to you as just the planning of it. And at one point in time, I was going to try and count up the number of meetings we had in the planning of it, but I just can't do it. It would take me half a year to do that, I think. So, but we came away with some key words that we wanted to incorporate here. It had to have that hometown feel. It had to have some comfort. It had to show that we're a caring staff and that we're a caring community. Compassion, familiar faces. We wanted our staff to be visible, if you will, when they were supposed to be visible. And then we also wanted some things behind the scenes when we're doing stuff that should be behind the scenes, if you will. Family, safety, friends taking care of friends. Those were the words that we came up with. It was really an interesting exercise to challenge ourselves after we looked at different facilities and say, what do we want to create here? We also wanted to create something that was efficient, an efficient flow of people, of materials, and information. Really in healthcare, if I oversimplify it, it really is the flow of people, materials, and information. You have to have the right staff at the right place at the right time with the right tools to do their work in order for us to be successful. So we wanted to design something that allowed us to do that, and that was really a key part of what we tried to do here. And I'll give you some examples of that in just a minute. And lastly on there, we really spent years literally working with our staff talking about their current workflows and then talking about how we're going to do it different in the new facility. And the worst thing we said that we could do is to take our workflows in our old facility and just transplant those in the new facility. Because a lot of our workflows in the old facility were predicated on the space or the limitations and whatnot. So if we were just say, we're just going to do that back in the new facility, probably wouldn't be as efficient as we can be. But to change the culture and to change the mindset, and that's not easy to do. I think you can appreciate we've got a lot of staff that have been with us a long time, and they're wonderful, and we really appreciate their knowledge that they have from years of service. But if you're used to doing something for 20 years and all of a sudden you're in a new facility and we're just going to say, we're just going to transplant that, we knew that we needed to work on that to kind of get a mindset that this is going to be new and different. Let's go into it with the idea of how do we make it as efficient as possible. Really proud of our team because I think they've done that throughout. So I want to show you just a couple of things that we've done to help us with the efficient flow of people, material, and information. So you see Glenn and I wearing a badge here. This is called Vocera. It's a company that makes this, but something that we've been exposed to at other facilities and we wanted to incorporate into our facility here. So one of the things that you may or may not notice, but as you're here, you're not going to hear any overhead paging because for the most part it doesn't exist, partly because I've told anybody if they overhead page, I'm coming after them, but also because we wanted to create an environment that was quiet and an environment that didn't have this kind of noise coming all over all the time. So anyway, the Vocera is part of that. So I think what I might do, I can call anybody I want to. I haven't prepped Kurt, but I'm going to give Kurt a call and talk to him here for a second and maybe ask you guys to give those guys a round of applause as I'm talking to him. So this is an example. If I need to reach Kurt, I don't have to go up and find Kurt, or I don't have to hope he's by his phone. I just push one button here.
Vocera.
Call Kurt Beisel.
Kurt Beitzel. Hi, Bill.
Hey, Kurt. Hey, I'm in Adventures in Learning down here and just demonstrating Vocera, but this group wanted to give you a round of applause for your great work.
Hey, thanks so much.
So you have to share that with your coworkers, is that okay?
I will do that. Thanks, guys.
All right, thanks. Bye.
Bye.
So if I see a spill on the floor as I'm going by, I'll hit a button. And I might know, like I knew to call Kurt Beisel, but I don't have to know who's in environmental services. I could just say, call environmental services. And as they logged in on their device in the morning, it will take me to the person in environmental services. Or if I'm a physician and I need to talk to the charge nurse on Med-Surg, I'll hit the button and say, call charge nurse. I might not know exactly who it is, but by title, it'll send me to the charge nurse. So this is a tool that we use to communicate, to create efficient flow of information back and forth. And it's something that, quite honestly, after about 3 days, I think we all wondered, how did we ever get by without it? Because now I don't have to walk somewhere to find someone. I can just hit a button, or I can talk to somebody as I even go down the hallway if I need to take care of something right away type of thing. So really became a great tool for us to use both for our clinical staff, our administrative staff, but also we've adapted it in a way that I don't think the company has seen before, but we also, if you come into the clinic, you might have seen it, because we'll give it to you as you come into the clinic, and this is how the nurse calls you back to your room now as well. So the nurse will call you and say, Bill, come on back to Green Neighborhood, room number 5. And part of the reason that we did that is we wanted to get away from the concept of we come out and just yell a name, in the hallway or in the waiting area. But we also wanted to create some efficiencies for our staff. Because if you think about the nurse in the clinic who might see 20 patients a day, how many steps does it take for her to go from her work area out to the waiting room and back? And if she doesn't have to do that, how much time can we save for her and then rotate into some other things? So there's some efficiencies and some customer service things that we wanted to use some tools to help us with. And this is an example of that. So now the truth is too, there's some funny things on here, and you guys, I'm going to show you this, although I tell staff they can never do this. So just one. So don't tell anyone that we did this, okay? Yeah, thanks. You're going to rat me out.
Vocera.
Beam me up, Scotty.
Sorry, the transporter feature is still under development.
I honestly did not know that some of this was part of it when we got these. It took staff like 3 hours to figure some of this stuff out. So it's not a toy, and we don't play with it, but it is something that really is a foundation now in our workflows and what we try to do with things. So this is called Vocera, and just the anatomy of the badge. And the beauty of it is it's just really one button to push, and we can do an awful lot with it. And even from a clinical perspective, if I'm walking down the hallway, or if someone in here were to have problems with their heart and I need to get the code blue team, I would push a button and say code blue team, and it would automatically go to the code blue team and just those people, and it would tell them the location where I'm at because there's a locator on it. So it's a clinical tool as well as a operational tool. We're going to take you upstairs in a little bit too and show you our tube system. So we talked about a flow of people, material, and information. So one of the flow of material, if you will, in this case, is our lab staff do an awful lot of blood draws, whether they're in the hospital or in the clinic. And we positioned our lab between the emergency room and the clinic because that's where most of their work happens. But we didn't want them to, again, spend a lot of time walking back and forth. So if you go to the clinic now, a phlebotomist will come to your room if you need blood drawn and draw the room from your exam room. And then in the middle of the clinic, we have a tube station that will tube that sample to the lab, or kind of like you've seen at the The best example is maybe what you've seen at the drive-thru if you go to your bank. It's the same kind of concept. So there's a tube station in the middle of the clinic, and there's a tube station in the middle of the hospital. So if someone needs their blood drawn in the hospital, we don't have to draw, in the morning the phlebotomist will maybe draw 4 or 5 patients every morning. So by the time I draw the first one, the way we used to do it, and the time I draw the 5th patient up on the floor and then walk back to the lab, it might be an hour. Well, that first sample, nothing was happening with that sample for that whole hour. Now, we'll do what's called one-piece flow. We'll draw the first sample, tube it to the lab so work can be done on that, and then I'm going to go draw my next patient and then tube that one to the lab so that work can be done on that. So we have single-piece flow and it allows us, or one-piece flow, and allows us to get our work done more efficiently. So again, that's what we incorporated into the design of the building to create some efficiencies for us. And we'll show you that as we take a tour today. And then some other efficiencies or things that are a little more upgraded or nicer here in the new facility is, we have a number of patients every year that we're going to need to take out by helicopter. And oftentimes it's an emergency situation or a trauma situation where we'll stabilize the patient and they need to get to a medical center that might have greater capacities or capabilities than we do, and they need to get there fast. So in the old facility, we didn't have a helipad, we didn't have a spot for that. We relied on the city to kind of help create a landing zone for us, and had to take patients kind of over some rough terrain to get there, but it worked. But now, we've got a helipad that is as close to the building as it can be legally, and it's right here for us. So, I just showed you kind of helicopter in, helicopter out, but they're going to come in whatever way they want to come in and land there. They can come in really in a small space. But we've got the capabilities now to do that, and I think we were open 1 or 2 days and had our first patient that needed to be helicoptered out of here. And it's a funny thing with that, it seems to go in spurts where you have none for a couple of days or for a week, and all of a sudden you have 3 or 4 in a row. So I'm not sure why that is, and I don't think I'll ever quite figure that out. But we have the tools and the capability to do that in a much more easy and convenient way now. And it's, again, going to be helpful for our patients if they need to have that service available for them. So just trying to give you some of the things that we incorporated into this, and as we give you a tour later, you'll see a bunch more, but try to give you a quick overview of some of that. Glenn, I think you're up.
Again, we couldn't have done this project by ourselves. And so we certainly do appreciate everything that the community provided to us, and we do want to recognize philanthropy in terms of persons who gave to the medical center to make this all possible. That was something that was really important for us to be able to recognize. So as you go throughout the facility, you're going to see different areas named in honor of different persons who contributed very much to the success of this organization. So you'll see in the facility, this is an example of this, the Harold and Betty Showquist activity room and family space, family lounge. We also do have the Jim and Sharon Wynell inpatient suites. And so we're just showing that we want to recognize those persons who gave so generously to us. The other thing, as you go through the tour, we do have a display honoring philanthropy in the facility itself. Not everybody can give significantly, but everybody can give some to the organization. So we recognized everybody who gave over $100 to the facility, and they're recognized on this wall of philanthropy. So on an annual basis, we'll change that out, but we do want to recognize $100 means a lot to a lot of people within the community, and everybody should be recognized for their efforts, and so we want to pay tribute to that. So that is something that we want to recognize. So how we did that and how we created a sense of working with the community, that was important for us, and that was a change that was needed as well too, was to continue to work with the community on philanthropy. One concept too that we worked with, and this is called the front of the house and the back of the house. So what we tried to do, as Bill even mentioned with services, we wanted to try to provide services as close to the patient as we possibly could. So when you enter into our building, the services should be readily available to you up front in the building. And so that was important for us, is to be able to make things convenient for you, whether it's through Vocera or whether it's getting to your clinic appointment, or whether it's getting to the lab or the radiology. We wanted to make all of that convenient. So the services that are provided back of the house, whereby we're transporting meals or we're getting laundry services provided to us, those are more back of the house types of services and not quite as visible to the community, but important to us to be able to provide those services. So we did work with that concept of front of the house, back of the house, providing services to the patient up front and center, and then in the back of the house working with our staff to provide services to the patient. Also too, we did try to put parking where it was convenient for patients, and so that's right out in front of the medical center. We do also have employee parking spaces, and so we wanted to make parking convenient for our visitors and our guests as well.
Convenient parking is something we never said at the old medical center.
Our neighbors are happy that we did move. So, but they've been wonderful to us, and we continue to work with them, and we'll do that as well too. But more back of the house types of services. This is what this slide depicts: is the locker room services, the services that are needed for our patients, and so those are back of the house types of things. So what are the next steps and where are we going? You know, what kinds of changes do we see that need to take place? We've already recognized some things, and so we're going to talk a little bit about that, our current state and our future state.
So we had a really successful move, and that was not a small feat. And I have to be honest with you, I've been in healthcare just about all of my career, and Glenn as well. And Glenn, you actually moved one other facility.
Yes.
And Glenn and maybe one or two other staff had actually done it in the past, because you just don't have a lot of people. They say, oh yeah, I moved a hospital. You just don't do that a lot in your career. So we're very proud of the planning that we put into to move the facility. We moved the clinic and services around the clinic, so lab and radiology and things like that, on August 4th. And then we moved the hospital and the emergency department and our surgical area on August 7th here. And really proud of our staff, because it was no small feat to make sure that we had all the materials and the processes and the workflows in place to be able to hit the ground running in the new facility and not miss a beat there. And we've done that, and it's gone very, very well, very, very well. Couldn't have asked for it better. Not that I want to do it again, but really happy with that. And we are fully operational in all areas of our building and of our practice here. So
the move has gone so well, my car is no longer driving to the old facility. It's driving me to this facility. So.
And we're really poised for growth. We had a wonderful open house. We had hoped to get 1,000 people at our open house. We had over 2,000 at our open house, and I don't think my legs and feet were so sore any day ever, because I did a lot of walking that day, but it kind of had a perpetual smile on my face, and I think a lot of people did, because it was just a wonderful open house. And I think, again, another example of the community's support for the hospital and that partnership that we've talked about. So. From that, though, we've seen some growth, and talk about that in a slide in just a minute here, but really growth with people who may be coming back to us and giving us another chance here. We recognize that as a medical center, we've had a history that hasn't always been perfect. I think a lot of those things we've worked through and worked out. We still have some bumps always, but we're always going to keep working on those. But some people that may have said, hey, I'm not going there, have come back, and we're really proud of that. And we recognize, too, that we earn our stripes on that every day, whether they'll come back again. And so we want to keep delivering on the service and delivering on that promise. I've also had some people who are giving us a try for the first time. Really pleasantly surprised with the number of folks from surrounding communities coming and saying, hey, I'd like to come here. Or now that I know that there's a facility in Cannon Falls, that's the one that always surprises me. I mean, we weren't that far off of 52 before, but we must have been hidden pretty well, because now I think I didn't know there was a facility in Cannon Falls, and I'd like to go there. So folks coming down from the cities and even some surrounding areas, that has really been a nice, pleasant surprise for us. And we had hoped that would happen, and it is happening. And that's part of our growth. And I'll show you a few more slides on that just here in a minute also. Future state.
Yeah, so we'd like to talk. We probably got 98.9% of things right from the beginning. So there are things, a building of this size, 92,000 square feet, there are things that you need to make changes with. And so when we moved into the building, there were certain things that needed to change. Parking, for example, our employee parking lot, we thought we had 90 spaces designed into the building. we started parking our cars for our employees, and we found that they were parking on the outer rim of the parking spaces, and that's because we did not have enough parking. So Bill went out there, the wise guy that he is, said something's not right here. We had counted prior to moving in that we needed about 90 spots to move into the new building. He went out there and counted on his fingers and his toes, and he came up with 72 spots. So the math didn't add up. So we were looking at some plans. The architects and the builders were looking at some plans. We found out that we didn't quite get our 90 spots, and so there needs to be additional parking. So we'll be working on providing additional parking because, again, we want to keep the parking out front for the patients and our guests and those types of things. So our employees will be parking in different locations. So to the east of the building, we will be adding additional parking to the facility.
If I could add to that, if Bill was so wise, we would have those parking spaces already and not. You know what happened is when we put in, we needed to have a wider turning radius for the MRI truck, the semi-truck that comes on Wednesdays for MRI services. And when we did that, that radius took away some parking spots, but in the heat of the process just didn't resonate to say, okay, what else are we doing to accommodate that, whatnot. So then, like Glenn said, I went out there's 72 spots. I swear there's supposed to be 95. What happened? And again, just one of those things that we got a lot right, but we did miss a couple things. And that's just one example that I'll take ownership for. And but we'll get fixed too, because obviously the fire marshal is not going to want us to be parking in the middle of the parking spaces where we shouldn't be and stuff. So we need to create enough spaces to have for all the staff. So my bad.
So we will be developing a healing garden. That's one thing we went out to the community, and the Rotary was really gracious in terms of working with us to raise some initial funds to get us to start working on our healing garden. So as you go to the Valley View Cafe, and just outside the Valley View Cafe, we are planning on developing a healing garden on some space that's out there. So we hope to be able to get that project started this fall. We'll lay some of the foundation and put that together, so we plan on getting that done. The one thing that's really nice about this particular project is the employees came forward and said, hey, we really want to do this. This is something that we want to do for the community, and we want to be a part of this. And so just as from the very beginning, the employees have been intimately involved in the project and working very closely with us to design and develop this, and they want to continue to take some ownership, and they want to work on developing this healing garden. So you'll see our employees out there who are volunteering their time to put together this healing garden for us. So that's exciting for them too. We do have additional shell space that is available for future expansion in the front of the building. Next to our meditation space, we have about 4,000 square feet, Bill? Yes. About 4,000 square feet of space that we can develop into future things, and we're trying to contemplate what exactly that should be. And so we're working with Mayo and our board and our staff to determine exactly how we should develop that future space. But maybe more geared towards retail types of services, but it's something, again, that we have to work towards, and we'll develop that. I did mention, the amount of land that we do have around the facility. We mentioned that we had 51. We sold some back to the state and to MnDOT to develop the roads, but we have 40-some acres to work with, and so we have upper plateau, and we have 10-plus acres that we've used for this facility with the parking and that type of thing. So we've got space up here, but then we also have a lower plateau that goes to the north of our facility that we can develop for future expansion as well too. So there is space. We're not landlocked like we were at the old facility that we can't provide future expansion. So we'll continue to work with our partners at Mayo, the community, our staff to develop that future space.
Where do we see some of that growth going? Well, our primary care capacity, we're at capacity. Too often right now, when we start the day, we have our morning huddle with our department managers, and we talk through what do we got going today and what do we need to make sure that we're clicking on, but we get a report, and how are we doing in the clinic? Well, too often the clinic is full. There's some same-day appointments that we leave open with every provider for someone who calls that same day, but we want to have capacity for folks to get in. And right now we recognize that we have it's not as, the capacity isn't quite there like we need it to be or want it to be. And again, that's just because we've had some growth here, and that's a good thing, but we need to manage that. So we have hired an additional nurse practitioner that'll start with us on October 22nd. Her name is LaSalle Johnson. She actually lives here in town, has been working in Rochester, and completed her nurse practitioner degree. Also plan on adding an additional physician to our practice here. Hope to have that happening by the first of the year. And there's no offer out there or anything just yet, but we have had some interviews and discussions and hope to make that happen. So again, that would allow us to meet the demand, if you will, and have access for you when you call in to say, I want to have an appointment tomorrow or next week and whatnot, and make sure that we're able to meet that need and demand on the primary care side of things. So working on that. Also, growth happening in a lot of selected areas kind of in that specialty clinic, and just listed some of our specialty clinic areas, but we've got a great group of providers in there, whether it be in psychology or orthopedics, podiatry, pediatrics, each of those. And you'll see upstairs what we have, our provider wall, where we have pictures of each of these folks too, just to kind of help you understand and see, put a name with the face kind of thing. But have some capacity in those areas and some where we're getting a little tighter, so we need to maybe expand some time or hours that they're here as well. So good things, positive things, but need to make sure we meet the needs of people as they come and want to have services here at the medical center. I'll just keep going if that's all right. And the emergency department is an area that's growing quite a bit, and really we saw that almost from day one when we opened the new facility here. Not sure if that's just because we're more visible from Highway 52. And some of our planning areas, we had heard that there's roughly 20,000 cars a day that go up and down Highway 52 past us here. And they think in 10 years that'll be maybe closer to 30,000 cars a day going past here. Some of those folks may have needed some kind of services from us and weren't familiar that we were here because of our old location, might not have been as visible from 52. Not sure if that's some of it. I think as a whole, healthcare is seeing the emergency room sometimes used as kind of that first access or first entry point into healthcare, when maybe it doesn't need to be the emergency room, it could be primary care or something else. But we're seeing a lot of growth there and have a close working relationship with local EMS and with Mayo One when we need to ship things down to Rochester as well. So great to see that growth. Not that we want people in the emergency room, but we have the space now to be able to work with them and meet their needs. In the hospital, Glenn mentioned earlier, we've got 15 private rooms, have an average daily census right around 10. Some of those patients are what we call acute care patients from the local community that just need to be in the hospital for whatever reason for a day or two or three or whatever. And some of those patients are what we call transitional care patients that may have been in the hospital in Rochester, don't need the destination medical center types of services in Rochester anymore, but they still need hospital care for a while, and they might come here for a period of time. But our average daily census has grown each year for the last several years. That's been a positive thing for us in terms of how we're trying to kind of reconnect with the community and meet the needs of the local community for acute care, also meet our organizational needs, because those transitional care patients, if we don't take them here in Cannon Falls, it might prevent someone from wherever around the country or even locally being able to get services in Rochester because they wouldn't have enough beds. So it's part of working together as a system, and it's a great way of us working together as a system. And then our surgery area, we're thinking that's going to increase. It has gone up a little bit, but tough to tell just being a month into the facility. But in kind of that surgical and procedural area, colonoscopies, things like that are part of the preventive services. All that kind of runs through our surgery department. But I think that's roughly going to go up about 30% in the new facility. Our old OR was 320 square feet. Our new operating room is 600 square feet. And one of the other mistakes I made in the building is I didn't have the speaker system so the surgeons could listen to their music during surgery like I should have, but have rectified that, and nothing worse than an administrator with surgeons mad at you. So we got that taken care of. So a lot of areas where I think we're going to see some nice growth with things, and that again allows us to serve the community better and well, and that's our sole purpose in what we're trying to do. So, Glenn, with that, anything else?
Yes, so we'd like to answer any questions that you have about the facility. certainly it's new to you and it's new to us, but we are very excited. Rosie, yes?
Yeah, I heard that you were thinking of adding cottages for
Transitional care, yeah.
I'll show you where that might be. It's harder to tell on here, but we have talked about that. And as you come in to the facility right here, we've talked about adding some what we call transitional care cottages right here. So those transitional care patients that we get from Rochester that Rosie's mentioning, last year they were from 10 different states, not Minnesota, and from Canada. So a lot of those folks are from Utah or Wyoming or whatever, and they needed some kind of services that Mayo in Rochester was able to offer them. But they didn't need to stay there after that kind of a, I'll call it a world-class care that only 3 doctors in the world can provide. They were further down the line, but they still needed some hospital care, so they came to us. Then what does the family do? And sometimes some of those patients are here for a week or 2 weeks. Some of them are here for a month or 2 months, and sometimes longer. So we had talked about that. We have a spot that we can do it in. We haven't pulled the trigger on, but that might be part of what the campus development may look like. Still a little bit up in the air. Does that answer your question? Okay. So we call those transitional care cottages, and really, in the plan that we had, Glenn, refresh my memory, I think we just had one level with a kitchen, a bedroom, a family room, and a bathroom. I can't remember the square footage, but really pretty vanilla, but maybe, if you're in a pinch and you need a place for a month, and while your family's in the hospital here, and you're from a different state, it might be nice for them to have, so.
Yes.
We noticed last night, and I've noticed several times, like we came from the Zumbrota area coming north, and we see the hospital, the H, out on the freeway, and showing where to go. But then when you come up and we take the 24 and go downtown, and the hospital comes this way, there is no H there to show the people. That is where to go to the hospital. So that might be a confusion.
Yes. Thank you for bringing that to our attention. We tried as best as we could to work with the various agencies, MnDOT and the county and the city, to try to get the signage appropriate. We'll take some responsibility for that, and I was working, on that project as well with that team. We have requested additional signage, so we have requested additional H's to be put up and that type of thing. So we are working on that, and I just recently was in contact with the county, who did say that on County Road 24 that they would put additional H's up for us.
I was
yeah,
just thinking for people out of the area that needed.
Correct. Correct. Yeah, there's other issues where we're working with Google Maps. If you try to Google Map us, you're going to be directed to the west side of Highway 52, and that's a complicated thing that we need to work with them and others, to get resolved. And I've got to say that, there was good intentions by everybody to try to get that done. And, unfortunately, it's more or less a live and learn type of situation. Until you experience it and you drive on it, we didn't know what to expect. And so thank you for that comment, though. We appreciate it. So
There's some kind of, what you're talking about, some of the, I guess I'll call programming that we need to put together around that transitional care program. And you're exactly right. There's some, I think, neat things that we can do, and I think patients and their families would really like some of that. So we've got the physical plan, if you will, the programming piece we won't forget about. Just takes a little more time to put together, but we'll get there.
yes.
These, whatever you call them there.
Voicera.
Yeah. So the nurse will not come out to get the patient? You give them one of these?
We give the patient an option. So when you register at the registration desk, the receptionist should talk to you about Voicera. We encourage it, so that's what we would like to do with the patients. But if a patient says, I don't feel comfortable with this.
Somebody old that wouldn't understand.
Yeah, right.
Yeah, they come by themselves.
Yeah, but certainly we want to encourage it. So we will encourage patients to take it, provide them with instructions as to how to use it. But certainly that's something that we are working through.
The nurses are really good about, they'll direct you maybe into the blue neighborhood, and as you in there, she's standing outside.
Oh.
I mean, she's in that hall. It isn't like she's
Right.
inside a room and you have to find her,
Okay.
so.
Okay.
Yes, Judge.
Glenn, I'm just wondering, the street lights out here now,
Yes.
they're not on yet. When are they
Yes.
coming on?
Yes,
I noticed that too, and I contacted the county to say, you know, I drove up late at night and the streetlights weren't on. And so they are looking into that for us as well, too. But certainly, there are streetlights at the end of our driveway there, and so they should be illuminated. But I don't know whether it's seasonally adjusted but again, they're working on that and looking at it, so.
Who designed the bump at the end of the driveway?
Thank you. Thank you.
You know, I appreciate bringing, because that is a serious bump. In fact, I got to get new shocks or something on my car just from going over the top of that. We are, that's part of the county road there, and it is a little excessive. So we are working with them to see what we can do with that. We were talking earlier. You know, there's a drain in the middle of that, so it's not just just pour more concrete or something. So we'll give them a little time, but we're working on that too, because it's obviously for you and I coming in, that's an issue. But think about the person in an ambulance, you know, going over that. That's a pretty tough bump.
I've been one of those.
Yeah.
Where that would have really, that would have been rough.
You know, that's another one of those learnings, like, you know, I don't know, I'll speak for Glenn. Glenn and I are hospital guys, you know what I mean? That's just what to do with the hospital. We know what to do, but I didn't think we'd have to get into, okay, wait a minute, there's too big of a bump as you come into the facility. But that is part of what we need to do, and it's part of the learnings that we're learning with it, and how do you work through some of those things that probably should have saw that one coming, but because I drove over and it's a big bump, but then you don't put together for a day, wait a minute, an ambulance is going to go over that as well. So.
Yeah. So certainly we do want to hear your comments. We are listening. It takes some time, you know, obviously sometimes to get some of these things corrected, but you know, as we continue to hear about those concerns, we'll continue to make the adjustments that we can when we can. So was there a question over here? Yes.
A sign up in Edinburgh Grove is quite a sign, 23 minutes.
I like that sign.
It's noticeable.
Yeah. And I think some of that again is working. So.
What's that stuff you and Bill got hanging on your belt?
This right here, obviously we have our cell phones, and then we're working with Mike to televise this presentation, and so we're hooked up with Mike and that. So, other questions?
Yeah. You know, I think the year we last delivered babies was 1996 or 4? 96? 96. So it's been, you know, roughly 18 years since we've delivered babies here. Well, I shouldn't say that. We have delivered 1 or 2, but it's been in our emergency department. You know, that's a changing area in healthcare. It really is, and could probably talk on that one for an hour. But suffice to say that there's a lot of hospitals our size that, you know, may or may not deliver babies depending upon your geographic area and how close the nearest larger facility might be. It's just an area of healthcare where to maintain the nursing staff and the physician staff and the surgical staff to deliver not just a vaginal birth but a C-section, and to have all that available 24/7, and to maintain the competencies for all that crew when you don't have a whole lot of it. And how you define a whole lot is the tough question there. It really is, because is that 100 births a year, or is that 75 or whatnot? And that's where I think a lot of folks grapple with it. But you know, we did talk about it. We won't be delivering babies here in the near future. I think really what we're going to see is more and more places our size or smaller just probably getting out of that area. It's just really tough to maintain that kind of thing and to do it well, because the last thing you want to have for a family and for an organization is a bad outcome there. And so I appreciate your comment, but
Obviously our relationships though, I mean obviously Mayo and working with the Red Wing facility, I mean certainly we can accommodate and take care of the prenatal needs of moms and that type of thing. So So we will work with those patients and then obviously make those referrals as well too, as appropriate.
So we do have a, kind of in that same vein, we have a pediatrician who's here one day a week, and I wish I knew that date exactly, but we'll have an OBGYN that will be able to see moms and whatnot here in the near future. And that will help, I think, provide that care to a certain number of weeks, and then the delivery can happen potentially in Red Wing or Rochester type of thing. So we need to solidify that a little bit more.
So other questions? Thank you so much for being with us today. We really enjoy having you here. We are going to have other groups come up, and we really want to get the word out for the new facility. So